All right, dear doctors, let's start one more time. This is your mentor, Dr. Shahriar, going to start the session and just previously checking the sound. And let's get started with this particular session. This is on a respiratory system. Today, we're going to do the recall. If you are not using any headphone like this, please make sure you use a headphone and the laptop device. If you're using the iPhone, iPad, you may not get the more features, but I believe we can go with whatever the sound we have actually. Great. About the respiratory system, we have gone through John Murtagh. John Murtagh, we started with the ninth edition last day. I hope so. You have already checked that one actually. All right. Great. Now let's get started with the respiratory diseases. You can see we'll be covering the respiratory diseases. No more comments, please. And there will be a 3 hour session coming up also today with a 3 hours, question answer session. Yes, and we are using the ninth edition definitely today. In between, I'll give you a break and this, that. Let's get started with the sessions actually. Great. All right. Are you guys ready to start the session? There is always option. You can raise your volume using your headphone. Now, speaking about this thing, if you're not using any headphone, try not to comment on any of these things. Would be better. All right. Let's get started with the very first one. We have already discussed some of the respiratory things. And here we go with our today's first question coming up. Yeah. So based on that, whatever we discussed last day, I want you guys to put a comment here actually. Great. Now here we go. 8 years child came with an asthma attack every month for last 6 months, and he takes inhaled salbutamol. So what to use for prevention? Yes, please. Yes, you can start your answer now. Okay, a lot of people are going with B, C, D, a lot of type of answers. All right. So mostly, I think people are choosing B. This is what we can say 8 years, so which is more than 5 years. So it is more than 5 years, and thinking something about the prevention actually. Okay, but this is ANC. There will be surprises and this that definitely. So here we go with the final answer is this one. Now coming to the point, why C? Any idea, any cases why I didn't pick up? Now C, inhalated fluticasone is also it is there. When you start preventive uh, medication, do we stop the salbutamol? Like think logically in an asthma treatment when we add the preventive ones. Okay, do we stop using the salbutamol? The answer is a no, actually. So we use rather in a combination as a step up. We never stop the using the salbutamol. Hence, B is a right answer, but C is even better. I hope that clarifies the doubt. This is the trick. You will often get tricked in the AMC because of choosing the a little bit more better answer. Is it clear, everyone? Please comment in the comment section. So C is a better answer than the B because you are using this thing in a combination. If you stop the salbutamol, it will not be good for the patient. I repeat, if you stop the salbutamol, it will not be good for the patient. Great. Moving forward, actually. Okay. We need reliever, preventer together, actually. A combination, my dear. Yes. Okay. 3 year child with a asthma attack and every 3 months for last 12 months. He takes inhaled salbutamol. I mean, there's a lot of similar stems coming up, so don't worry. So what do you use for prevention? So what do you use for prevention? What do you think? Question clearly said, already using salbutamol. So what do you use for prevention? I saw someone is also answering A. Terrible answer, we would say. Probably didn't understood anything in the first class, I guess. Please see, it's they are asking for prevention and already he's taking salbutamol and now they're having attack in every month. So first question is coming in your mind, is this situation is controlled? Every month they're having an attack. Every month they're having an attack. So do you think this is the right answer? What do you think? A is the right answer. It is no way. Now there's a B and there is the C, but as per we discussed just now, inhalated salbutamol fluticasone, a combination actually. There is no way this can be an answer in this case because this has been used already. So what do you use for further prevention? This will be best answer actually. Guys, those of you who are answering A, you need to double check everything actually. Yeah, wonderful. Great. Similar kind of more questions are coming up. So if you collectively think later, you may get up to a certain point. Great. After the today's session, we'll open or create a inquiry zone. You can ask me even more things. Now, best preventer in a 4-year boy, asthma is relieved by salbutamol. What's next? I request some of the doctors to answer once I finish reading the question. Okay, just nothing to be, I mean, too fast. Uh, let give others to answer and think. Actually, some of you could be very fast. So again, the same thing. Best preventer in a 4-year boy, asthma relieved by salbutamol. What to do next? Please note, in this case, this is less than 5 years. Previously, some of the cases were more than 5 years. Now, in this case, do you think this is the right answer? When age is less than 5 years, right? So I think salbutamol being in used, and as a step up, probably you want to use ICS as a fluticasone, but ICS is recommended usually after 5 years. So best answer probably here will be, what do you think? Best answer, okay, best answer would be probably here uh, for this one. Yeah, for this one, I think best answer would be using the B. So B is the right answer in this case. B is the right answer in this case. Already mentioned in the last class, less than 5 years after introducing the reliever, that is the salbutamol, if you need to step up a preventive, less than 5 years, we try to use sodium chromoglycate. More than 5 years, we try to use fluticasone, which is the steroid. Up to this, are we clear, guys? If anyone is attending for the first time, you need to double check the class which we had with the John Murtagh 9 for the very first time. Yeah, will be really, really useful. So SCG is the better answer. There was an extra thing. We have removed that question from the new file, but there was one in past. So you see this one, someone with a severe asthma, and always check the age group with the 5 years admitted to the hospital. Now they have been given some drug which also includes salbutamol, steroid, and all the necessary drugs actually, including the LABA as a combination, probably also given. Now, at the time of discharge, which is the one drug that is particularly has to be? I mean, if you remember, I give you guys or tell you guys a real life story where we talk about the importance of one particular drug last time. Yes, and it was definitely steroid, but which is the form of that steroid? Is it the fluticasone I talked about, or is it that oral steroid? So at the time of discharge, definitely 100% oral steroid. So there was a relevant question, but this question hasn't been tested in last 3-4 years, hence I removed from the main file. But just keep it in mind, at the time of discharge, even oral steroid, at the time of night symptom or acute exacerbation, or maybe the hospital is distant, even in that cases, oral steroid can be life-saving. Did you remember the level A evidences actually? Level A evidences of the highest level of, evidence where injection hydrocortisone equals to oral prednisolone. Am I right, miss? Injection hydrocortisone and oral prednisolone. Correct? Wonderful. All right. Next question coming up, even relevant. This time again, 3 years, which is less than five. Let's quickly finish this one. Recurrent asthma attack. Probably monthly he's getting an attack and talking about a best preventer by inhalation. Previous day in the class, we talked about something like that, like a mode of a preventer which is given by inhalational route. Okay, so I clearly mentioned, like we already knew that through the nebulizing machine and this, that definitely you can give the steroid as inhalation form. But the question is here, less than 5 year, sodium chromoglycate is the choice. So my question is here, is sodium chromoglycate available in inhalational form? Did you guys remember if you flashback all the thing? Sodium chromoglycate, is it available in inhalational form? Answer is a yes. I clearly highlighted separately. So sodium chromoglycate as a inhalational form. Check it from the John Murtagh ninth edition of the asthma. Yes, that table. Well done. And here is a small thing for you as well. This nutshell to remember is a asthma as a prophylactic in children less than 5 years, sodium chromoglycate, and to be mentioned, sodium chromoglycate available as a inhalational form actually. Asthma related, you can get a lot of information, especially if children's asthma, RCH guide, right? Okay, RCH means Royal College, Melbourne. So Royal College, Royal Children Hospitals, or this asthma.org.au and asthma related, all guidelines. Even though if you check the John Murtagh and also anything from the RACGP or RCH will be more than enough. Moving forward, moving forward. 5-year-old boy presents to the ER due to asthma attack and has a 6 puff of salbutamol. All right. And not improved wheezing. So, what to do next in this case? If you remember, there was a question like that, like a 6 puff, 12 puff, or in between the interval. Did I mention something like this? Like in a 20-minute interval, these things are given. Did I mention this thing in any previous class? Like, usually these intervals are like a 20-minute interval. So in a 20-minute interval, you keep giving this salbutamol. There's another few things we discussed last time, which was rule of six. Did you guys also remember that one? Example, if someone's age is 6 year, and there's another thing to remember, 25 kg, right? So if all these things are below this, we can continue with the 6 puff, even as a repetition. If the same situations are like uh, let's say, same situations are more than 6 year, more than like a 35 kg. Okay. So this one and more than 35 kg. In that case, how much? Like not 30, I mentioned 35. 6 year and 35. This one is a 12 puff. I haven't seen ever 8 puff related question coming. 8 puff one, even though given in the John Murtagh, but I have only seen so far in my last 5 years 6 puff and 12 puff relevant question coming. So one, they can give you the weight thing, one, they can give you the age thing. Most cases in AMC, this age related informations are given more. Okay, please remember these things. Shall we move to the next one? Yes. So now you understand why that particular theory class is more important, right, guys? Like so far, whatever the recalls we are trying to solve. So my classes are more based on the to the point for the exam. So it's a more exam specific class. Now you tell me, guys, do you want I explain more about pathophysiology, or do you want me to teach in the same way where questions based actually? I mean, even theory, but more based on the exam specific. So more pathophysiology based or more exam based actually, because honestly, like pathophysiology based. Actually, it's more some cases fun. I know that, but we try to make a blend actually. Yes, yeah, we try to make a blend actually. Blended is more better. I try to explain, yeah, but at the same time, yeah, because some people have a lot of gap, and over the time you can cover up those things. But there are so many people, they are fresh graduates at the same time. Yeah. So nowadays there's so many YouTube videos. Say if you don't know about asthma, you can search in YouTube. You can find so many the basic videos if you have forget. But I think I should definitely add things which is related to exam. So I usually try to do what, so that the class does not get boring. I try to usually make some blended actually at the same time. Like if you remember, I explained the clinical feature relevant things, and then some of those exam specific. Great. All right. So hope you remember that one. There was a thing called level evidence. What was that level evidence? Nebulizer and using a spacer device. Nebulizing spacing device actually. Yes. Uh, I'll guide you guys later, especially those have longer gap, how to cover up those problem. They need to study a little bit more than the person in that case, actually. Okay, great. So here is the thing in case of six puff and the 12 puff thing. And also it's not about that after gap, a lot of people, a lot of concepts will be new in MC at the same time. Here is the thing, another thing from the RCH guidelines, 6 puff if less than 6 years old, 12 puff if more than 6 years old. So again, and from another different reference actually, right? So it is like more clear reference, this time from the RCH. So John Murtha, and we also try to cross verify with RCH or RACGP guideline. So are you understanding the study pattern a little bit now? We usually try to follow John Murtha initially. Then as a support, we use SMA note because some few things are also not given in John Murtha, and to the point things you get to know from SMA note. And then some cases double check few things from RSCGP or RCH. So did you understand the pattern? Usually I try to follow this particular guidelines. There's more website. Time to time, I will tell you more. But this is the basic, guys. So those of you here for the first time and you feel little lost, so first follow John Murtha. Secondly, the notes we supplied, because those are more to the point for the exam. See, interesting fact. Is it easy to make bigger notes, or is it more easy to make short notes? What, let's see your opinion. Like, say, if you see, go to our SMA note, those are more exam oriented short note. So, do you think is it more difficult to make that note, or is it difficult to make longer note actually? So I think you will be agreed. Nowadays, it's much more easy. There's Wikipedia, there's so many things. It's much more easy to copy paste things and make a very longer notes, right? It's shorter notes, especially if those are specifically comes in exam, even more research is required actually. So, and one more very important thing people are forgetting, which one is easy to remember at the end? Because at the end, everything you have to revise together. Then the point of shorter notes will be play a part. So SMA note, you also definitely revise before the exam. Moving to the next one. Right. Every year a lot question comes from John Murtha asthma section. Yes. This one I think we have finished already. If you can see a similar kind of question with a 5 year, and there was a atopy history, and they're asking about something prevention in a inhalational mode, a similar kind of question. And this one's answer would be sodium chromoglycate, right? SCG. Chromoglycate and SCG is the same thing. So you can see another similar kind of question. And here is that particular reference from the chart, if you remember. The sodium chromoglycate also available in the inhalational form. So can we give SCG inhalation mode? Definitely it is a yes. And here is a John Murtagh reference. Moving forward, guys. All right. Okay, child who's wheeze and cough at night and during exercise given salbutamol and the fluticasone. What is the best preventer in this particular case? Alert, this question can be tricky. They're asking best preventer. Let's say this child's age group is like say let's say 7 years. Let me clarify. This child's age group is like a 7 year. Now many people are thinking, okay, it is maybe only a question related to preventive. And if it is like a 7 years kid and this that or whatever it is, you probably will think about the C. Uh, Fact checking. Is this a typical asthma question or is this a exercise induced asthma question, dear doctors? This is a typical asthma question or this one. I told you guys last day, please try to read exercise induced asthma as a separate topic, right? Last day we discussed something that exercise induced asthma try to deal with separately. Now come back to the, is this the typical asthma or is this the exercise induced asthma category? This one is an exercise induced asthma category as per discussion of the last day. Is this one, is this particular thing exercise-induced asthma, what was the best way preventive as per the RSCGP? I clearly remember I mentioned that one to the point. So exercise-induced asthma, the best one we have mentioned. What do you think? So best one we have mentioned. All right. All right. We have mentioned as a Saba short-acting one. This one. If you all remember the last day. Saba was the best one as per the Excel. Then there was combination like Saba in a combination of Lava or Saba in combination with Montelukast and this that. Those were as a combination, but the one of the best one is a Saba. Reference RSCGP. Great. Here's a little bit different question. First few questions were those preventive, inhalational mode, and this that as per our lecture. Now, this one is a 50-year with a asthma and a hypertension. They can also have reflux nephropathy and investigation given. There's high urea, high creatinine, and proteinuria. Proteinuria is, you can check the range. So, what is the best choice for this uh, hypertension? I think in the very first slide of asthma, we discussed about the risk factors. And we clearly said one of the drugs that should not be used. Okay, one of the drugs that should not be used is AC inhibitor. So the question is, what is the choice? So many of you are choosing losartan. Now, question is losartan is a AC or ARB? I repeat my question. Losartan potassium, is it a ARB or AC inhibitor? That is the question. Amlodipine is a calcium channel. So final answer is a losartan, which is a ARB. So some people can choose perindropil, some people could choose amlodipine, but yeah, so ARB is preferred. All right. This chart probably you can take a screenshot. Maybe this chart was not there last in that slide, even though few drug names I have mentioned. But some of the drugs that can induce asthma, starting with ACTH, ACE inhibitor. ACE inhibitor by means of production of cough, and when you cough, you can't take breath. So that aggravate the asthma. There's more other like painkiller, cholinergic, radio contrast. Okay. Even some Antibiotics can also cause this thing to happen. So most important is inhibitor to remember. I give you 10 more seconds. You can take a picture of this one. Great. Please make sure you don't share it to outsides actually. So ARB, more preferred. Patient with pulmonary edema, saturation is 90%. Now, saturation 90%. Saturation or oxygen saturation related, was there any topic we have discussed last time? I think we did. So this one is less than 92% with a 6 liter. And what is the next step in the management? This is given as a less than 92%. So many of you are choosing the BiPAP. The question is this the range for the BiPAP? Or the BiPAP range is 85% or less than 85%, right? So I think this better thing we go for a non-breathers, BiPAP, CPAP, intubation, which is related to uh, 85% or below. Okay. So here is a little something. If oxygen saturation, let me highlight less than 92%. In that case, like you give nearly this amount of oxygen by non-breather. Non-breather. I hope that's clear to all of you guys. I hope that's clear to all of you. Here's another line is given. If oxygen saturation is uh, after giving this thing yet less than 92% or directly if it comes around 85%, then CPAP, BPAP, those are important. Here's another line in the beginning. If you get a range like this, like mild hypoxia, it's like that 86 to 91. This is our range earlier, that 90%. So we give a non-breather or a venturi. Severe hypoxia is noticed 85% or below, which is the CPAP or the BPAP or the intubation. Is this thing clear, everyone? Is these two charts related to oxygen delivery system? Is these two things are clear to everyone? I believe we do. Okay, next one. Okay, I'll just hold here for a second if you want to take a picture or something. Last time we have shown that one, even though, just for a second. So this one, first of all, and yes, this one too. This is our answer area. This one. Next, a known asthmatic patient. Many times they can tell you the patient is known claims of asthma and already probably has taken some of the treatments. Presents to the emergence of status asthmaticus. Now, status asthmaticus is a nothing but acute severe asthma. Before added to the oxygen, he took salbutamol inhaler but didn't improve his symptom. What should be given next? So something has been given which did not improve the symptom. If you remember the last day real life story being mentioned, the patient died because of not giving one particular drug. That is the oral steroid one. Very important. If you try something and not working, definitely oral steroid is a lifesaver. Okay, now this chart is taken from Davidson's medicine. I'm sure you all are familiar with Davidson. Sometimes Davidson medicine charts are really, really good. Okay, so life-threatening or acute severe asthma. Okay, as per Davidson, of course, we do the ABG. If you remember, I mentioned if the hypoxia is severe, the breathlessness is really severe, ABG is really important. So asthma cases, COPD cases, we can always do the ABG if acute severe cases. Now we try the ABG, then nebulize salbutamol, this, that, high flow oxygen because it's asthma. These particular things may not be enough. In that case, definitely prednisolone or hydrocodone. See, again, that level A evidence actually. Okay, so prednisolone or hydrocortisone, both of them showing similar kind of efficacies. These are one of the level evidences. So this was your question. One more time. I will post this file, so don't worry. You'll get the questions actually. Definitely write down the answers and this that. All right. Next one. Child with a fever, 39, and history of cough as well for 3 days. And there was wheeze. Sometimes lines can be a little cracky because some cases can be recolors line. Minimal lung sign and X-ray given of a pleural effusion. So fever, pleural effusion, child. There was history of cough. Okay. As for investigation, what to do for further investigation? What do you think? So should you go for a pleural aspirate or a blood culture at this point? Best tool to assessing the diagnosis at this point. Now, for even any suspected, pneumonia or this kind of cases, definitely you need an X-ray, which has been done already. And see, pleural, uh, fluid aspiration, we go step by step, but we need to be a little bit more sure about. So what we can do in the beginning, we can send a blood culture. Now, if culture and these things is all combining, and then if needed, you can go for pleural aspirate actually, pleural aspirate. Okay, great. Not all cases of pneumonia we go for pleural fluid aspiration. I'm sure many of you are uh, renowned consultants or even practicing. So, do we really do always pleural fluid aspiration for pneumonia cases? Not always, but I think that X-ray and that blood culture is most cases, maximum we do actually before pleural fluid aspiration. Pleural fluid aspiration basically we do if something else in our mind actually. Now, if you remember this way of diagnosing X-ray, then comes the blood culture, then if necessary, pleural fluid aspiration. There's another way of diagnosing in the respiratory system. This one is for the infection cases. Another way, X-ray, then there is a CT scan, and there is a biopsy. If you remember this two, rule one and the rule two. So rule one for the infection cases in the lung, rule two for the other cases, chronic cases, complex cases. Okay. Please mention in the comment section if it is clear. So these are the step of investigation. If you do, when the cardiology will come, you'll see we'll also talk about similar kind of thing. Like when you go to the cardiology, there will be the similar things like ECG. We start with often with the ECG and this that. All right. Okay. In cardiology cases, actually. Then there will be echo. Then there will be catheterization, right? So there's a way of investigation for every system. If you master it, yeah, it'll be really nice. Okay. Again, I mean, ruling out this thing. Our question, please come to our question. This looks like because there was fever, child, effusion. This is looks like an infection. Now, if it's an infection cases, don't I mean it's very common we start with the X-ray. Then comes because it's an infection. Tell me, is it necessary to do a blood culture for infection cases? Definitely, it is a yes because we need to choose the right antibiotic. Some cases we start the antibiotic, then the blood culture thing comes as per the blood culture, either we keep the same antibiotic or we changed it. Some cases we are not sure that disease is not improving and this, that, then further we think it can be something else. We go for a pleural fluid aspiration. Or maybe some cases it can be also transudative or something different, maybe tuberculosis. In those cases, definitely we need to do pleural fluid aspiration. Is it clear about the rule number one now? Like any suspected infection like pneumonia, like tuberculosis, those are the infective ones. Now coming to the point, let's say cancerous cases like lung cancer, like the mesothelioma or any other interstitial lung disease or fibrosis and many other similar kind of cases like this. In those cases, can we say, again, we start with extra, very basic. Even lung cancer, we can get coin-like lesions. Sarcoidosis, we can get bilateral. Okay, and next is very important because these are chronic diseases. You need a high resolution thing. Like what? Like a CT scan thing, because these are chronic and very complex things. So you need a like microscopic view, kind of. So you need a CT scan. Agreed? And further, you need to know what type of cancer is this or what type of interstitial disease is this. Then we go for the biopsy to rule out it is a small cell carcinoma or a squamous cell carcinoma or any other very chronic things. Is it clear to the dear doctors now? All right, good. Okay, all right. Again, for practice is a similar kind of question. I mean, exactly didn't mention the fever, but it would be high, like 40 degree or 39.5. Children, fever, cough. I mean, it's a recall, so a little incomplete in the question side. And also extra showing effusion is similar kind of question. And now this one's answer, I'm sure all of you can answer. Yes, and you all are correct in terms of it's we send the blood culture and immediately by sending the blood culture, then provide the antibiotic. So D first, then C. Agreed? D, then C. Yeah, it's not like we wait for so long. I mean to say we don't wait 3 days for the blood culture. Like we just draw the blood and then start the antibiotic. We don't start the antibiotic and draw the blood culture. A very similar kind of question, compare and contrast. You will get it for meningitis cases. Someday when I will teach you the neurology. All right. Now in neurology, you will also find there is a two type of meningitis. I mean, there's so many types, but for the purpose of study, one is a pneumococcal meningitis and one is a Neisseria meningitis. Which one is more dangerous, guys? Pneumococcal one or the Neisseria one? Definitely the Neisseria one with a rash, with adrenal gland failing, whole body like a DIC. Very dangerous, actually. Now, the question um, for pneumococcal meningitis, our step of management is usually pneumococcal meningitis cases. We do the blood culture, then we go for antibiotic. It's given in John Murtagh meningitis chapter, you can check it. Question, in case of Neisseria meningitis cases, can you do the same? Like, okay, you are thinking of going for a blood culture first. Question, do you have the time? Neisseria meningitis, your patient is already dying. It's Neisseria, so adrenal gland and this that, so you give a like forget about your test first to save your patient. So we give the antibiotic and then you can consider the blood culture. Okay, very important for MC exam, this particular thing. So MC will try to confuse you with very basic things related to practice. Is this thing clear, everyone? So in contrast with pneumonia, we also compare the meningitis one. Especially in meningitis, there's two types. One is a less dangerous pneumococcal. One it is extremely dangerous is a pneumococcal. If you remember things as a compare contrast, will be really helpful for your exam. Yeah, I was talking about that. And here is a more detailing lines. In meningococcal meningitis, emergency antibiotic, and then comes the yes, Neisseria meningitis. Yes. But whereas in other meningitises, like a pneumococcal cases, we do the blood culture first because we have time. And in this cases, no time. Just to clarify more. All right. And we are going for more things. Here we go. In Australia, always check, if the question is mentioning about in Australia, sometimes they can ask you about statistics type of question. Whenever they say in Australia, it is probably a question related to, okay. Now, most film cause of death in a like previously 3 years old. What do you think? Can it be viral pneumonia? Okay. Because we're discussing pneumonia, some people may get biased. Okay. So MC will always try to bias you. So do I sometimes in the classes. It's actually drowning. Tell me one thing, if someone is an adult in Australia, what is the cause of death? Number one, it's a road traffic accident. Okay. I know why would it be depression now? Australia is very sunny, so interesting fact check, guys. Again, a compare contrast. Now, guys, when I do the compare contrast, do you like it or you don't like it? Let me know. I mean, um, it's the same question I mentioned as a 1 year because there was a question like that. 1 year. Now, already mentioned adult one is the road traffic, but what about the 1 year kids? Now, 1 year kids actually related to this thing. Sudden SIDS is also, maybe you have seen like this SIDS, sudden infant death syndrome. That's one of them. I mean, often you don't know the cause. Yes. Then little bit grown up, there's the drowning because water everywhere. That makes sense. Yeah. So yeah. So by the 3 year, it is rare, like the SIDS cases. By the 3 year, we think more about the uh, this particularly downing cases. They can go here and there. Probably 3 year age group, they don't know how to swim as well. Interesting fact check. Is it possible that a 2 year kid can swim? Let's see, I mean, your ideas. 2 year, 1 year, can they swim? Interesting, right? Actually, they can, and in some cases, even better. No, not possible. Actually, if you check some videos, the swimming packages you will find in Australia, like even before started walking, the new study says they can swim even better. Before learning the walking, I mean, by after 1 year, right? They started to walk for 10 months or something, 1 year. So that particular time, if you put them into the pool, because it's new for them, they don't know anything now, neither the swimming, neither the walking. The how you will put them, if you tell them that you are a fish, so probably they will believe that one at some point. All right. Yeah, yeah. See, someone is mentioning yes. So it's not uncommon. So this is the new concept, and it is actually true. And there are so many packages in Australia. Somebody will go if you have that kid under 1 year. They're also training nowadays, and popular job nowadays. Yeah, and especially those trainers earn a lot. By the way. Okay, coming to the next question. A child 7 years come with fever and looks tired and lethargic and grunting. Let me tell you one point. This word grunting is very bad. Write it like this. Grunting word is very bad. Okay. On examination, chest is clear and what is the diagnosis? But the grunting word is there. Think 7 year lethargic grunting. Even though mentioned chest clear, but what it could be. We're expecting some more radiological finding, even though. Okay. Uh, quickly thinking, can it be bronchiolitis? Chest clear, nothing mentioned about ways. It is more than 1 year as well. Uh, less likely. Okay, so now pneumonia, epiglottitis. Yes. we are going for this thing as a pneumonia. Now, do you agree these two conditions will be associated with stridor, which is also often given in MC exam as a abnormal breath sound, or sometimes they mention barking cough. Now, I haven't taught you guys pediatric yet, but in pediatric, I will teach you guys this topic more, especially this epiglottitis, croup, bronchiolitis, this thing. This thing I will tell more. Okay. Okay. All right. I think this chart will help you even more. This chart will come again in our pediatric or already available in the P4 pediatric section. Just giving you a little glimpse of this thing. Um, in between these three conditions, like pneumonia, we just learned pneumonia associated with a high fever, respiratory difficulties, cough, all these things, right? The typical pneumonia. And there's three other conditions like croup, epiglottitis, bronchiolitis. Bronchiolitis, I can say that below 1 year and will be associated with wheeze, which is another abnormal breath sound. Whereas croup and epiglottitis will have associated with there is stridor. Some cases, croup cases, barking cough as well, not only stridor but barking cough. Okay, so these are the key things. You also need to remember their causative microorganisms, especially bronchiolitis, RSV. All right, I'll teach this thing again in the pediatrics, so don't worry regarding this. Okay. So since we have fever, lethargic, and the word grunting, if you check the pneumonia part, the grunting word is there. The grunting word you will find there actually. Pneumonia, again, at the same time, there is typical pneumonia, there is atypical pneumonia. So there is a lot of variations of pneumonia. Pneumonia has so many variations. Okay. So typical, atypical, so many. This question itself is not fully clear, by the way, but we expect if epiglottitis group, this thing mentioned, in my experience, the question often given abnormal sound, which they said just is clear. Whereas is bronchiolitis, they usually mentioned about wheeze at least, or the age is supportive at least, which is not. So this is the method we are using here. We call it exclusion method. So for the very first time, I'm showing this thing. If anyone has gone through exams, competitive exam like MRCP or anything like that, they must be knowing about exclusion method, where you don't exactly get the full question, then you remove one by one and get into your final diagnosis. So if it's not straightforward, yes. Many time, my dear, I mean, again, this practical thing came up. Do we clinician always get pneumonia in just finding? No. Not always, yeah? Very common. These are the things will come in real life practice. Not always you'll get to see. Yeah, so you need X-ray and all this thing. That is the reason. Many pneumonia cases are hidden. So that's why you need an X-ray. Clear now? Yeah. All right. No doubt about the last question. Let's go for the next one. Now, coming to bronchiectasis. Now, it's again small one. Original question will tell you someone is having hemoptysis, breathlessness. It's a chronic case. Okay, some cases they can give you a CT scan finding, where you can get tram track, like a tram track appearance. Right. Right. So, what would be the treatment? So superimposed pneumonia, let's say think more about the gram negative, probably. So here, what we are thinking more about going for IV. ticarcillin. This one will give a much better gram-negative coverage alongside gram-positive coverage. Speaking about the bronchiectasis and going through their CT, yeah, abnormal and permanent dilatation of the bronchi and the bronchiole. Some cases, tram track appearance. Maybe you can Google it more for the tram track appearances. Yes, abnormal and permanent dilatation. This is a case where you need interval antibiotic. Did I mention that one? Or rotatory antibiotic. Yeah, here is that line. We mentioned about rotatory or interval antibiotic, like one weekly every month. Prophylactic antibiotic, very rarely probably you have heard about this. So chest physiotherapy, blood culture, rotatory or interval antibiotic, some cases surgical resection may be required. How to confirm a cases of bronchiectasis? Most accurate test would be high resolution CT scans. Initially, definitely we start with X-ray and then high resolution CT scan. Clubbing can be possible. Crackle can be possible on examining the lungs. Clear, everyone? Please comment in the comment section. Showing you the question again. This is the question. Little small though, because bronchiectasis can lead to pneumonia, and the better coverage would be if you cover the gram-negative things better. So ticarcillin certainly give better gram-negative coverage. Of course, when something has a gram-negative coverage, it also has coverage on the gram-positive. More into radiology, this is how the radiology of bronchiectasis. Let me tell you something, guys. One website that is I really like for radiology is a Radiopedia. Okay, so Radiopedia is a really nice um, website for checking any high resolution X-rays and the CT scans. Great. Yeah, you can see very much dilated the bronchi and the bronchioles. Yeah, here's a thing called tram track. Somehow you need to imagine actually. Next one, 65-year with a history of smoking. Now came to your office, peripheral edema, raised JVP, jugular reflux. Now, some of the cases of respiratory gives rise to heart problem, right? What is that particular condition which can a lung cause related to, yes, leading to a heart problem, which includes the core pulmonary, also known as the, is it right heart failure or the left heart failure, guys? The core pulmonary, is it right heart failure or the left heart failure? It is more related to right heart failure. So core pulmonary. So you can see hepatojugular reflex, raised GVP, edema. This is indicating congestive cardiac failure or the right heart failure. Interesting thing in a cases of core pulmonary, even though right heart failure, but there will be an existing problem in the left heart. And did you understand this point? Probably not, actually. Often it is seen core pulmonary cases, see, this is the heart thing, this is the right side, this is the left side. The mitral valve in which side particularly? I repeat again, mitral valve, is it in the left side? Is it in the right side? It is definitely in the left side. So mitral valve from the left atrium, then blood passes to the left ventricle. Now, if you have a problem in the mitral cases, let me draw that one. This is the heart. This is the left-sided mitral valve. This is the lung things actually. So vena cava, then from the right atrium, right ventricle, left atrium, left ventricle. This is the mitral valve. Now, if you have problem here, stenosis, narrowing, blood cannot flow is it possible it will start affecting the lungs? Do you agree? If problem in the mitral valve, your left atrium will be affected first, and then your lungs will be affected. Eventually, this right side will get affected actually, right? So increased left atrial pressure, increased pulmonary venous pressure, pulmonary venous backflow, yes. Okay, eventually pulmonary arterial pressure, initially vein, then the atrium. Okay, so that is that core pulmonary thing. Is that core pulmonary thing? So eventually there will be right heart failure. But often in core pulmonary, there is a left heart problem. When there is a left heart valve problem, that leads to right heart failure. Now clear, everyone? When you have a left heart valve problem, okay, then it leads to right heart failure actually. Now these are the clinical features of the core pulmonary. Often the patient who has COPD has more chances of core pulmonary. It can lead to right heart failure. They can also have mitral stenosis. This leads to shortness of breath, which is common in every heart failure. Then there will be enlarged tender liver. It can be over the time. Raised jugular venous pressure over the time. Yeah, because of the backflow again. Okay, it's like a traffic jam, backflow. Right? Yes. Yeah. When you have a backflow problem, like the blood cannot come here, so backflow, which also gives rise to JVP. Eventually, this backflow comes to the liver, so there will be engorgement, so enlarged tender liver. Okay, so we can correlate everything, like why there is raised JVP, why there is enlarged tender liver, and because of the pressure, hydrostatic pressure, there will be leaking of the blood fluid, that plasma. So in the interstitial space, so there will be more fluid leading to edema. Right? Clear explanation. Pathophysiology, I also love it, but not always you need it for MC. But yeah, it is what it is. Okay. Clear about core pulmonary? Maybe you just need one more time practice later with your study partner. So please make sure you have a study partner actually. After today's class, I think from Saturday we'll close the group. Admission process will continue till mm, this whole month, but the group will be closed. Only those took an admission will stay, and rest we will be gradually removing. And they can always get back after the admission, definitely in that case. Okay, so no problem. And about the material, I think by tomorrow, 5 p.m., I'll be in the office. If anyone from Bangladesh wants to visit office, more than welcome tomorrow. And at the same time, I'll be clearing all your materials tomorrow by Bangladesh time, 5 p.m. actually, which Australia time would be like 9:10 actually. All right, that's the information. A patient recently traveled to Asia, cough, low-grade fever. Okay, didn't mention which country, but from Australia traveling to Asia, pain in the epigastrium, chest extra. What is the diagnosis? Yes, please. So after traveling, someone can get something with a low-grade fever. Okay, so many say it B actually. Honestly, the duration has not been mentioned actually. So cough and low-grade fever, but after traveling to Asia, most cases people actually bring viral infections actually. But they should have mentioned one thing, the duration. So a patient recently traveling to Asia with a calm, like so let's say it's like a first 7 days. After the patient coming back in first 7 days, actually, we think more this thing as a pneumonia. If it is more than 2 weeks, if more than 2 weeks, then only you think about the tuberculosis. Okay. So I'm sure in the main exam they will tell you the exact duration. But since say recent traveling to Asia and now developing cough and low-grade fever, we are thinking this thing as a pneumonia. Yes. That's a vague one, dear. Your chief complaint is here. Get familiar with these things in MC. Real patient will tell you a lot of things, my dear. Understand vague things, right? I mean, It's not related to this one. Patient may have his own other problem. Patient don't always tell you, okay, I only have lung problem. Patient comes to you, tell I have lung problem, I have mental problem, I have this problem, that problem. It's kind of like that. Okay. So always this is the trick. Always focus into your chief complaint. Traveling to Asia, number one point. Number two, and most important, cough and low-grade fever. After a recent travel, always think about the viral pneumonia, viral pneumonia, viral pneumonia. Very, very popular question, travel medicine related, especially pneumonia related. Okay, great. It's a very common question, by the way. I'll give you a brief by the end of the medicine, something related to travel. Okay, then I think the intubation period and few of the other things would be even more clear. So pneumonia, pneumonia, pneumonia. This one again, a oxygen delivery. I want your answer in next 15 seconds. I'm not reading this question, but you can answer as quick as you can. So a lot of things are written, blah, blah, blah. And important thing is at 85%. So if it is 85%, our answer is going towards the CPAP. So it is going towards the CPAP. Already discussed similar kind of thing. And here is your answer. And here is our answer. Here is our answer. Moving forward. Old woman 75 admitted to hospital with a cap. Remember, this pneumonia can be a lot of type, community acquired pneumonia, hospital acquired pneumonia, pneumonia in a immunocompromised patient. Right. Now this one community acquired pneumonia, he receives antibiotic well on the day 5, now develops um, fever again. What is your explanation? Big question. Can it be hospital acquired pneumonia using exclusion method? First thing that comes to my mind, maybe it can be hospital acquired because it's in the hospital. Okay. Unfortunately, that's usually first 48 hours. First 48 hours. So it is not. Now, if someone having pneumonia and again develops fever, what it could be? Now, it's very close between B and the C. Okay, when you saying IV cannula related, which is a wrong answer, it's emphysema. Number one complication. Please remember about pneumonia, always number one complication of pneumonia, emphysema. Emphysema, emphysema. Now, why it is not IV cannula? IV cannula related things always mention there is a swelling, tenderness in the IV cannula area. Actually, the red is hand is tender and this that. He has a pain in the venous line. Okay, this kind of things will be mentioned in the IV cannula related bacteria. This one is a very classic question about the M5. Okay, great. And why not hospital acquired? Because mention almost fourth day. Okay. This is a weird question. I don't know why it comes all the time. But anyways, it is what it is. Waldenstrom macroglobulinemia, even though a bit hematological condition. Classic hematology does not really come in exam except for few one, two things. One of them is this one, Waldenstrom macroglobulinemia, which is by the way is a cancer. Patient comes with chill, regular fever, some infection. And since there was infection, so there was ampicillin antibiotic started. Now, patient develops rash and asking for management. If you give any drug or something and rashes and started, it's always very important. You need to stop the offending agent. Now, this is very popular in the exam, especially about stop, so stop offending agent. This can be very popular in AMC in terms of an option. I've seen a lot of questions similar like they stop the offending agent. Those from the previous batch, did you remember one to uh, similar like this, stop the offending agent? Let's say let's compile. Let's see some of your memories. How much do you remember? Like stopping the offending agent. Now, any drug allergy cases, I mean, of course, this is stop the offending agent. Anything else? Anything which I probably highlighted? in the last batch? No one? Okay, one more thing. I mean, at least let me tell you. Let's say Epstein-Barr virus mononucleosis, EBM, Epstein-Barr virus mononucleosis cases. You know, small kids can present with tonsil problem, and you give ampicillin, and they develop infectious, Epstein-Barr virus mononucleosis. Often it can be because of this ampicillin, there's rash can happen. There's a picture given in the journal that I will show that one in some of the end section in the medicine. So even in that particular cases, we'll stop the offending agent. Now, to the exam point, we have to remember a few things actually. So see, some of you joined from the previous batch by renewing in just $50. But see, these are the things you need to remember, guys. This is the things you need to practice. All right. Okay, I can give you examples. So any unknown pieces, new batch, so not a right time to give those examples. Maybe we continue a little bit and I can give them more examples like that. Okay. So cis ampicillin related to Waldenstrom macroglobulinemia or any type 1 hypersensitivity, any offending drug, we stop that drug. Also Epstein-Barr virus mononucleosis, we stop the offending drug. Okay. Just remember this compare contrast. It can be useful for your exam. Next, patient went with his wife to Thailand and came back, have dyspnea and altered consciousness. Wife is well, and as we prepare to intubate, no further sputum was noted. Temperature, please. What is the likely diagnosis? Yes, please. So just after coming back from Thailand, so okay, so high temperature, breathlessness, and all this thing. So perhaps maybe pneumonia, meningitis, those things more suspected again. Now, some of you can think, Doctor, can it be pulmonary embolism? The question is, can it be pulmonary embolism? Now, for pulmonary embolism, the flight should be a long flight. Always remember that. Like a flight from UK to Australia, flight from US, Canada to Australia, considered really long flight. Also, one more thing, if you look into the clinical features, you know, uh, do we have that point, chest pain? Because in pulmonary embolism, one of the main feature is a chest pain, right? In fact, in cardiology, our classes will start with the chest pain differentials, and pulmonary embolism will be included into that one. So we look into long flight, we look into chest pain. These are the missing points actually. So by exclusion method, we are removing it. DVT again, same thing because of long flight things. So that is out. Now only thing remains is the malaria and the pneumonia actually. Now this point maybe can go in favor of malaria, but again the question depends more on the you know uh, the intubation period. Yes. And besides, traveling to Thailand, Bangkok is not a very endemic area for malaria. Okay, malaria cases usually if someone goes to the hilly areas separate, hills, mountains. So malaria is specific. Another thing actually you can consider as an E option we have seen in the question in past is a rather dengue, right, everyone? So dengue fever is instead you have to be a little bit more careful, especially so first weak fever, very high chances viral fever, pneumonia, and also this dengue thing, also the typhoid thing. Great. Okay. So pneumonia looks to us temperature, dyspnea, and all these things more towards the pneumonia instead of malaria. But again, intubation period will tell you better in the exam. Here is few points, few extra notes. I'll give you a few seconds to copy this one and read this one a little bit. Like say air conditioning cases, Legionella, burn cases, burn patients, Pseudomonas, general pneumonia, strep. Often they have rusty sputum as well. Okay. Alcoholic, abscess, Klebsiella, AIDS cases, pneumocystic carinine. Okay, so I'll hold few seconds here. All right, guys, let's finish two more questions and then go for a break. Old man, long time with a productive cough and yellow sputum. Is that develop lower lobe pneumonia? What to? So already mentioned it's a pneumonia. So and a old elderly person. So elderly person's pneumonia, high chances strep pneumonia. Now in that case, what do you think? So I think we prefer going more with this one as an answer place. So green sputum indicating also gram negative more probably. See, ampicillin covers more with the yeah, but it can be anything. First, for any pneumonia cases, there's certain things. One, mild, moderate, severe. Then you also look into gram positive, gram negative, and all these things. So we prefer this one because we have this thing here, green, yellow, green sputum. Can anyone tell me yellow, green sputum or green sputum can indicate which particular microbe? What do you think? Yes, definitely it will more towards the pseudomonas thing. Because do you think ampicillin will be better in pseudomonas? Not really. Definitely this one will be better. Next one. This time it's less than 1 year with a complaint of fever, cough, tracheal tag is a key point. Intercostal recession means intercostal indrawing because the person is having respiratory difficulty. Came to the ED, you give him IV fluid oxygen. Your diagnosis less than 1 year, fever, tracheal tag, lethargy. It's very clear case going towards the bronchiolitis. Bronchiolitis. More something related to bronchiolitis. Whenever you uh, read about bronchiolitis, by the way, for the bronchiolitis, it is not given mild, moderate. This is a pediatric topic, but even though the bronchiolitis will be discussed in John Mutter, they didn't mention as like pneumonia, mild, moderate, severe. But when you go to the RCH guideline, they discussed about the mild, moderate, severe, and we also see questions sometimes related to mild, moderate, severe. So please take a picture of this one, can be useful later. All right, 60-year male with a 2-month history of cough, dyspnea, and 2 days history of hemoptysis. What is the diagnosis? Now, this one, there is a two thing. Higher chances, cough, dyspnea, elderly age group, nothing mentioned about fever. Okay, so it's a possibility of going for a lung cancer. Now, you can be thinking about good pustules. Why I didn't write it as a good pustules? Anyone? Good pustules, I remember as a 2H, 2H. Some people say H, some people say H. So 2H. What is that 2H? We do have one thing, hemoptysis, but for this one, hematuria. This term is required. So it's an autoimmune. So hematuria, hemoptysis. Now, why it's not pneumonia? No high fever. This is the single most important point to rule out the pneumonias. Um, Next is a TB. For tuberculosis, usually again the same thing. We consider the low-grade fever, night symptoms, lymphadenopathy. Okay. Also, travel history. So they didn't mention any travel history. Usually in Australia, you don't expect TB unless travel actually. Yes. So if we go again by exclusion method, so hemoptysis, cough, dyspnea, and longer history of cough, as you can see. So longer history of cough, we are thinking lung cancer. Longer history of cough, you can think about TB, but for Australia, TB is not common unless there is a travel history. Is this clear to everyone? Shall we move to the next one? Yes. So it's a lung cancer. Last time we had a detailed discussion on the types of lung cancers as well, right? Some of them are central, some of them are peripheral, some of them are very deadly, like small cell carcinoma. Many of them are related to uh, paraneoplastic feature, right? Did you remember that part? So paraneoplastic, cortisol up, SI-ADH up. Did you remember these terms? Like Cushing feature and lung cancer, SI-ADH and lung cancer. Also, squamous cell carcinoma also has a paraneoplastic feature, which is PTH actually. It means parathermon will raise. It means calcium level will raise. Bronchogenic carcinoma, elderly age group, definitely smoking can be always been very important. Extra line to remember. Is this situation is related to asbestos exposure, guys? Yes, last time we learned this can be related to asbestos exposure. Lung cancer, also we have notes in the SMA note section. So you can learn about uh, risk factors of lung cancer, types of lung cancer, paraneoplastics, and asbestos exposures. Last motion before going to the break. A 52-year patient recently diagnosed with lung cancer. Didn't mention which lung cancer, now weight gain, and also few features like this. I hope you start guessing which feature is this. On examination, moon face, buffalo hum, even blind can make a diagnosis now. Now, this one is most likely, what do you think? All right. All right. Something sometimes we, as a fun word in our country, like I'm from Bangladesh, so there's a very interesting thing we called bamboo. Okay. Bengali we call it bash. So those of from you here, you understand. So the bamboo is kind of like, what you are supposed to get and you're getting opposite. That's called bamboo. And now this thing you will get a lot in the MC exam actually. Now ask this thing, and many of you quickly jump, oh, this is Cushing. But is it Cushing? Only Cushing. There is a lung cancer thing included. Now, do you have an even better answer? The answer is a yes, we do have a better answer. That is the ectopic SCTH. Ectopic SCTH is the indication of a lung cancer with Cushing feature. So you can see E is correct. Now, how many of you get a bamboo in the first hand? All right. Don't hesitate to mention your own name as a me. It's okay. With the time, we will progress. I mean, we all will be bamboo resistant. Life is about there will be so many bamboo, and we just have to be resistant. Bamboo will keep coming, but it doesn't matter that, we allow bamboo to give us bamboo. All right. Fun apart. Okay. Should we take a break now? Should we take a break now? Guys, a 10-minute break. Yes. All right, guys. So let's take a break because some people has a small kid. Yeah, small babies. Some people also have larger babies, you know. So you can check into with your small babies, large babies. Yeah, so I don't mind. Then come back after 10 minutes. Thank you so much, guys. Good everyone. So thank you so much. Let's get started. All right, here we go with the next question with a 50-year this time with a history of renal transplant. This is the key point. Whenever you see renal transplant or transplant, please mark this on the list with the point next stiffness meningitis started 3 days ago. Nothing mentioned about respiratory syndrome, no fever. On examination, there is a round opacity. This is a radiological finding. What is the cause? So, uh, round opacity, as we can see. Yes, this one. But not much respiratory symptom, unfortunately. Now, what do you think? Please note there is a history of transplant. So anything, any respiratory condition which can be related to renal transplant. Yeah, pneumocystic kidney pneumonia is a good option. Aspergillosis is a good option. TB related, not much information like travel or this, that. Unfortunately, I don't think so. Also, not many people are considering nocardiosis as well. Nocardiosis also is a good option. Okay, final chance. Let's go for final. And here we go. We picked up this question as a aspergillosis actually. Okay. All right. Now coming to this point, let's read this one and go back to the question. With a renal transplant, we understand this is a cases of immunocompromised. So which brings us to the point of two things. One, it can be aspergillosis, even TB, even nocardia. X-ray finding will exclude the tuberculosis definitely because they mentioned like some sort of round opacity. As per the X-ray, if you find this thing as a round opacity, you will think more about the aspergillosis. If your finding mention it's a focal, then it would be nocardia. If it's mentioned patchy opacity as per the X-ray in this thing, you think more as a tuberculosis. Are you clear with this radiological finding? So, key defining factor was the chest X-ray. Key defining factor was the chest X-ray. Already immunocompromised. I repeat it again, immunity compromised. So it can be aspergillosis, can be TB, it can be pneumocystic, it can be nocardia. Well, with the transplant cases, aspergillosis, TB, nocardia are priorities. So we'll think in between these three. As per the radiology, no, uh, you know, patchy opacities or, mottling or anything like that. So it's not a TB. Nothing mentioned about focal, so it's not nocardia. Remember, nocardia focal. Check more X-ray related to nocardia from the radiopedia. And round opacity, like you see the fungal ball, round things, this goes more with the aspergillosis. Whereas aspergillosis is also common in immunocompromised cases. So is it clear, everyone? I mean, how to tackle this kind of question? I think this question is a little bit difficult one. The 26th answer is certainly A. Great. Okay, here is a few things about the occupational lung disease. It was available in the John Murtagh. This is also a chart. So you see pneumoconiosis, coel minors, pneumoconiosis, silicosis aspiratus. They have risk of core pulmonary cancer, Kaplan syndrome, and this that thing. Whereas asbestosis can be related to lung cancers. Yeah, this thing. Risk of bronchogenic carcinoma more than the mesothelioma. Asbestosis often affects the lower lobe. Also, asbestosis can be associated with pleural effusion. We have seen in past a mesothelioma picture with X-ray showing pleural effusion. It can also happen in case of lung cancers. At the other hand, silicosis can be also important. Sandblasting, mines, this can be important actually. With given X-ray finding having ground glass appearances. Great. Moving forward, guys. Or I keep it for a second if you want to take a picture. It's also given in the assignment, by the way. It's taken from one of the textbook actually. Oh, great. Next question. All right. Get familiar with this term. Are you familiar with the term aborigine? Guys, please comment in the comment section. Are you familiar with the term aborigines? Yes. So aborigines are their local people. Australia has histories of like you can see white Caucasians, but the before the Caucasians, the white people came there. There was like elderly people like Indonesian Red Indians were there, so that they are the original Aboriginal people. Now, Aborigine with atomas, mitral stenosis, left-sided heart problem, dyspnea, chest texture showing basal creep, which can be an indication of heart failure. No fever, no cough, no fever indicating TB probably out. X-ray showing bilateral perihilar opacity coin-like lesion. Interesting. Now, what do you think? What is the right answer? Okay, some went for sarcoidosis, but it's not sarcoidosis. It is pulmonary hypertension actually, because the person has a left-sided, yes, this thing with the point, the basal curve. Whereas in case of sarcoidosis, we get like crackles and those things actually, not the crepes actually. Okay. Also in sarcoidosis, the finding is bilateral hilar lymphadenopathies. Bilateral hilar lymphadenopathies. And here said perihilar opacities. It's not the same thing, right? Great. Coming to the pulmonary hypertension, um, organized by pulmonary arterial hypertension, which you can also measure by sending catheter to the heart. Okay. Also, left-sided heart disease. Did you mention that mitral stenosis can be often given? Yes. We saw with core pulmonary tube. Right. So that's the thing. And also lung disease. Yeah, and these things. Great. Okay. I hope that's clear. The last one. Next, an Aboriginal female has MS and dyspnea. 6 weeks on examination, she had lung basal crackle, a temperature this, and yes. So, what is your diagnosis? Again, Aborigine, again left-sided. So, I think not a big problem. So, we'll definitely go with the yes. Uh, Anything related to pulmonary hypertension, right heart failure, often. Now we have to check is this one is a um, left heart failure by any chance. So I think it's a pulmonary hypertension. Aborigine, it can be given. See, interesting point. You know, mitral stenosis, dyspnea, even anything rheumatic, these are more common in Aboriginal age group actually. Okay, so we'll go for the answer here. The word mitral stenosis is more than enough to diagnose the pulmonary hypertension. Okay, a similar kind of scenario with the Aboriginal woman presents with mitral stenosis, shortness of breath, low grade fever, and this that for 6 weeks. Bilateral basal cramp. So Aborigine mitral stenosis is this kind of question. We usually go with the pulmonary hypertension. Some of the cases, there would be radiological findings too. So in this radiograph, if I want to highlight something, so it's indicating pulmonary vasculature. Okay. A 4-year-old with a cough and wheeze and intercostal recession, he uses his accessory muscle while breathing. He has fever and on examination clear chest. He is treated with IV fluid. Which microorganism is responsible for this condition? So it's a 4 year, not like a 1 year. 1 year it can be little different. So okay, let's see this question. Review this question. Apparently, first look will go here. Strep pneumonia, no doubt on that. Now coming to the point of ways intercostal recession. If we collect all these three, is it going more towards pneumonia or is it going more towards bronchiolitis? Even the bronchiolitis, the commonest age group is like under 1 year, but it's usually common. It doesn't mean it cannot happen after 1 year. It can definitely. So, cough, the wheeze. Wheeze is never a part of the pneumonia, honestly. And also intercostal recession and the fever. Why we picked up this one? Because respiratory syncytial virus is responsible for bronchiolitis. So only thing that is not matching is age, probably, but rest of the thing are matching. Please have a look on this question. If you have something to add, feel free. So here is a term, bronchitis can happen in some cases after 1 year. Definitely it can in clinical practice. Okay, agreed, guys. Please, in that case, please mention as agreed. In bronchiolitis, fever is also common, my dear. In fact, in pneumonia, we expect more high fever, like 39.5, 40, even higher. Yeah, viral fever as well. Uh, few keywords like, yeah, looks to me viral. It can be respiratory syncytial virus. That explains the better thing, like intercostal recession more for the bronchiolitis Intercostal recession is an indication of the tracheal tart thing, which is an indication of respiratory distress. Wheeze again going with the same thing. Cough again going with the same thing. Thank you, guys. Not every question need to trigger no explanation of that like that because these are microorganism names are given, not disease. Okay, 55-year male with a COPD patient came with the shortness of breath and oxygen given by venturi mask and this that and certain things are given. So, what do you think? I think our this is a COPD patient, and another key thing can be the saturation. So I think all can be right, but I think saturation is less than 85%. Your patient's situation is not good. So intubation or CPAP. So which one do you think is the right answer? So CPAP is the correct answer. Little reference from the radiobarian, COPD. Have a look on the COPD. First of all, because it's a barrel-shaped chase, we can see more air trapping. That's why the lung is looking a little more black than the usual. And this artery is the bronchovascular like markings more prominent. So barrel-shaped chase, more air trapping, bronchovascular markings. And of course, with the clinical things, you can diagnose. This can be a case of COPD. We do have note in the note section. You can also have a look. All right. Adult girl with a adult maybe 35-year girl with no history of chest disease come with pneumonia. Saturation is given like this. So what's next? So just I think given 85%, I think it's CPAP. Okay, next one. At the end, I think our everyone's battery goes down with the time. Uh, X-ray showing so, but try to be responsive. And some people try to, especially those with mobile and tab. Why I don't recommend they start trying to sleep. Please mind it. I can open your video. Okay. Right. So X-ray showing just hilar shadow bilaterally with abdominal pain cough. So what's your diagnosis? I think it's a clear view. It's a sarcoidosis. Sarcoidosis, something we have discussed earlier. Sarcoidosis from our yeah. So here the main point is the one of the unique things that bilateral hilar lymphadenopathy. Yes, which is the main unique thing. Also, few of the lines given from the John method. So bilateral hilar lymphadenopathy, fever, arthalgia, it's a multi-system disease, and erythema nodosa. All right. We have also discussed sarcoidosis last day. Here's a picture again and again coming bilateral hilar lymphadenopathy. Here is a investigation, usually X-ray, CT, then the biopsy. Some of the other uh, tests you can do simultaneously to get more evidence like AC and calcium, but more non-specific test. Usually don't find any physical finding except for some cases inspiratory crackle. Okay, main keyword hilar lymphadenopathy. Moving to the next one. Hilar lymphadenopathy. Old woman, very old actually. So admit to hospital because of CAP, community acute pneumonia, antibiotic given, and discharge when done suddenly develops rigor, chill, and high fever. So what do you think? So it's a pneumonia, and then there was a complication of pneumonia. Again, similar. Emphysema is the answer. Emphysema is the answer. I think another similar 2-year child with this that looks like a pneumonia. So we go with, in this case, oral amoxicillin. Now, why oral in this case? Oral syrup or something. Why not IV in this case? It's because like no marked respiratory distress. So some places they will tell you marked respiratory distress, tracheal tugs, or grunting. Okay, so it's a mild case. Everyone agreed? So this is a mild case of pneumonia. This is a mild case of pneumonia. All right. So mild case of pneumonia, you can test this thing as a oral amoxicillin. Google it, my dear tracheal tug. Already mentioned it actually. I think it was in one of the previous question actually. Yeah. It's a sign of respiratory distress. Tracheal tug is a sign of respiratory distress. I think 3, 4 questions ago you have mentioned that. So looks like some people have short-term memory loss. All right, great. All right. So here you can see pneumonia, mild, moderate, and severe. Okay. Also severe pneumonia. Last year we discussed as a CORB or CARB 65. It's okay to give oral from it, unless like main like more severe thing mentioned that actually. Okay. Some doctors are not stick to the academic things. If you start ruling out like weird things, you'll be in real trouble in MC. Okay, lady has been traveling to aeroplane, and I ask you, request you guys to be more focused at the end. Yes, because I also need to focus while taking this class. 1 minute break, please. Thank you. All right, everyone, let's get started. Okay, next few question, I will not read the full stem. I'll just show the uh, questions and we'll go for explanation. I need to rest my voice a little bit. Okay, so here is the question. So let's try the answer first. All right, everyone. So we have decided this question as a uh, pulmonary embolism. By the way, guys, after the class, we'll open a inquiry zone in our Facebook group, Batch 65, where if you have any questions, you can ask me there. I'll get back there. Actually, I'm not following the chat box now because I need to be focused on the remaining classes. All right. So, turning off chat box. Okay. A lady and has a long history of traveling. Then we have mentioned this thing like from UK. Let's stay focused. Ask questions here this at this point because we all are tired. So UK to Australia is a very long flight. All right. And this gives rise to a very dangerous condition to pulmonary embolism. It is highly recommended in case of traveling through the air. You can do some maybe walk or any movement or like a press the calf areas. Okay, highly recommended. Especially the elderly people are more recommended. But understand one thing, it can also happen for anyone actually. Especially anyone is on certain drugs is more higher chances. So here, the number one uh, key thing is following travel dyspnea. I repeat this thing, following travel dyspnea. So leading to pulmonary embolism actually. Pericarditis here not relevant. You are supposed to have pre-existing heart disease or recent Coxsackie virus, which is different. And pneumonia, it's not quite related here. Usually you're expecting more high fever and other things like that. All right. We do have a question, and this one is cracked actually, honestly. And this one, we took that answer as a giant stroke breathing. It's a new form. We are also not much familiar onto that one. It's called capnography. I'm also trying to understand the capnography. So this was how that question been, we have collected. Someone just mentioned CTO2 question like that is hypoventilation. We believe the answer can be giant stroke breathing. So you keep doing your research. Once I get to know more about it, I will update it more actually. But I found the question is a bit incomplete actually, and this I'm not very familiar with this particular topic yet actually, capnography. All right. So capnography, you can also start reading by yourself or Google it, or once I make a note or anything new on that one, I'll try to upload or update once I get a more full version of that question. Okay. Okay. Let's come to next one. All right, here is the question. I'll give you 30 seconds to read it and answer it. All right, everyone. Here is time for your answers. So this is a case more related to work related, where people are exposed to asbestos, and of course they are familiar with this thing. Asbestos can lead to cancer. So as a doctor, what would be your suggestion? Is it a point to go to a respiratory consultant at this point or not? That is the main key thing here. C is totally out of option here. It's like nothing. So as a reference, so repeat the X-ray in next 5 years. I mean, first we need to rule out if there is any asbestos-related lung getting affected. From where I'm telling this reference, so here you will find these lines. So asbestos X-ray periodically or like a 5 yearly. So there here is a some informations about it actually. So based on that article, I think repeat X-ray in next 5 year is more recommended instead of referring to a respiratory specialist actually at this point. We have already have SMA note regarding this with the asbestos exposure more related to lung cancer, and also there is a mesothelioma, but lung cancer over mesothelioma. Okay, next question. Small question, 65-year with some sign symptom exercise lung cancer. If we highlight, we can see probably a coin-shaped lesion. So what do you think the best possible answer? By the way, X-ray has been done here already. So since that's next, we already discussed about it. So we are going for a CT scan here. As per previously discussed, X-ray, then CT, then the biopsy. Remember this, guys? X-ray, then CT, finally, further what type it is, we confirm by biopsy. Other than this particular cancer, don't forget to read about the pancreas tumor, right? We also discussed about that one little. Young boy after episode of severe bout and chest pain, 12-year went to the ED, refilled 15% pneumothorax. So you give him morphine after analgesia. What is the initial management? The doctors, if you have any further question after class, we'll open an inquiry zone. You can ask your answers there in our batch 65. Okay. There would be one or two options very close. So it's a pneumothorax relevant. So in that case, I think, if you remember that one, there is a thing called 25% related to pneumothorax. Did you remember this thing from the last discussion? Pneumothorax, there was a 25% lung collapse thing. Okay. Now, the question is here, is this a symptomatic case? Severe bout of cough. Which point guiding you towards it is symptomatic? Tell me in one single word, which point do you think guiding you towards uh, symptomatic? Okay, quick question. Is chest pain is like uh, for pneumothorax main key feature? Of course not. In case of pneumothorax, the key thing is a dyspnea, my dear. Simple chest pain can be because of gas problem and many other things. It's a dyspnea, my dear doctors. Don't make these mistakes. Okay. So we'll admit and review. It's like even cardiac cases we also do. Okay. So admit and review this particular thing. So it's a asymptomatic, again, asymptomatic plus 15%. 15% is less than 25%. So final, as per the John Muttak, if you remember, I think we had slides and this, that. Yes. So no symptom, dyspnea symptom, and our case 15%. It is observation. Everyone clear about this? Pneumothorax, this one? It is. Okay. We're heading towards the end. Last day almost there was a last topic, TB. TB, there can be pulmonary TB, then immigrants TB, and there was another one, latent TB. Looks like a question like that. 25-year male, presence with cough for 21 days, and atypical opacity. On X-ray reported and Montox is positive. No history of previous immunization. Please mark this one as a key. What to do next? So there's a cough for 21 days. Now, again, interesting thing. Do you think it's a symptomatic TB or is it a asymptomatic? First, we need to rule it out. Are you thinking this thing as symptomatic? Because I remember I taught this thing us. So, cough particularly is a number one for tuberculosis. I repeat, the low-grade fever and particularly the cough, especially it has been promoted. If you have a cough for 2 weeks or 3 weeks like this, you definitely get tested for tuberculosis. So it will be like a symptomatic and X-ray done, which is not fully clear. And but he also has a Montux positive, so definitely you should order sputum for AFP for further ruling out it is a tuberculosis or not. Very high chances it can be an active tuberculosis. Here was the chart I was talking about. So TB, active TB symptom, yes, because in our case, the cough was like more than 2 weeks. Okay. So X-ray, and then of course the sputum is mandatory here. Guys, is it clear so far the latent TB and the active TB differentiation? I hope it is a yes. Uh, Please note it is almost the same question. Lastly, we choose order sputum for AFP. What do you think is the answer now? Now, if I show you the previous answer, there was no option E. Now, this time we just had an option E. Now, do you think is it yet the A is your answer or a disease like TB, which Australian government really afraid and is isolation is the first job you should do. Even if you suspect, the first job you should do is isolate the patient, then keep the ongoing treatment. Okay, so isolation first and then the ongoing treatment. Actually, in every hospital, there are isolation wards. So you can do that. So here is the thing isolation. So a question like that. So A is the right answer, but we do have a something better we can do at this point. Hence, E is the right answer. And it's the same chart. 55-year male presence comes with a history of weight loss, with a facial congestion and prominent neck pain. On examination, no breath sound in upper. So, what is the cause of the symptom? Lung cancer, superior vena cava. Now, that's a weird question, actually. Both of them looks to me is more correct, but that's a superior vena cava obstruction sign because of Pentecost. Actually, right answer, I would say superior vena cava obstruction due to Pentecost, probably. All right. So, technically, both of them are correct in my mind, actually. Yeah. So, it's a Pentecost tumor. No, that superior vena cava obstruction itself, it is due to a lung cancer. I think the missing puzzle is that particular line. So they might tell you squamous cell carcinoma, they might tell you superior vena cava obstruction due to pancreas, they might tell you adenocarcinoma. Makes sense? I mean, they will give you all they'll give you mesothelioma as well in the option. So out of many lung cancer, actually you have to choose. What I believe this question is actually. Understood? Okay. All right. Great, guys. So thank you so much for attending to this session. And the question file, I think I have posted. Sorry about long class. And I did post something about our inquiry zone. If you just go and check here, something like this, your inquiry about respiratory system. If you go to our relevant batch, and if you just whatever related to this class after taking some rest, I can answer it there. If you have any inquiry about related to courses and anything, you can also ask there. Okay. So yes, thank you so much for staying with us and good luck. And yeah, little long classes. And you'll get habituated, guys, on this particular point, actually. Great. Some of the no questions can be tricky, but AMC is kind of like that. This is how we are running the show for many years. We are very experienced overall, like, it's understanding the question pattern and this, that actually is very much doable, my dear. Actually, well, from our academy, it's honestly 1,900 doctor passed. Actually, if you go to our Czech Shares Medical Academy, we have two pages: Shares Medical Academy page and MC Online Coaching. Because I'm from Bangladesh, initially started Bangladesh, so you can see there are like I think 900 review in the page one, and there's like 700 reviews in page one. All right, and already posted about the notes. Tomorrow, 5 p.m. Bangladesh time, I will clear all the notes actually. All right, so it's okay, guys. I mean, I have seen doctors even 49 years. I mean, so you can understand that maybe 20 years later joined and then also cleared the MC. So that can be inspiring for it's just matter of like some time. You will get through there. AMC, like, see, officially website passing rate for part one is 50%. For part two, it is 20%. In our academy, AMC part one passing rate is over 90%. AMC part two passing rate is over 60%, actually. All right. Yes. All the best on that one. I mean, those of you who have taken admission, I think, and send us the receipt copy. Definitely, we will send you notes tomorrow. That's the update, actually. All right. Okay. And mock would be on next Sunday after the class. Actually, I'll tell you how to take the mock. So must attend the next Sunday class, actually. Great. So next Sunday, we'll have a, right, live class, actually. All right. I'll talk about those things in future. So don't worry. We have a whole 5 months ahead. And best of luck to all the doctors regarding this, actually. Yeah. We do have a opened our inquiry zone. So if you have any further question, because it's everyone must be tired now. So you can ask me anything here at that zone, actually. Yes. Good luck. So signing off, guys. Good luck. Yes, for MCQ respiratory next Sunday. After GIT class next Sunday.